Let me double check the recording is working and just until the transcript is started. And I think we will announce last week winner. Okay. Still still the question of the facial nerve palsy. No one answer it, so I will not give question this week. I will wait until someone to answer the facial nerve palsy. Okay, so I will announce the winner. I already announced the winner on the WhatsApp group, but you know, they deserve at least to announce them also in in the teaching. Okay. So do you see the case, Dr. Satwat? Are you able to see Satwat?
Yeah, yes, Dr. Aslim. Yeah.
Yeah. So I will start the 3 minutes. You are 3 minutes and the 12, yes? Or if there is any modification, no modification?
No modification, you say?
No, no. Do you, I mean the timing 3 and the 12, or there is any modification in your timing?
No, no, that's fine. That's
3 and
fine.
the 12. Okay, okay.
Yeah, yeah.
So I will start the 3 minutes. You just when you read, when you reach the bottom, you tell me what you know to go down. It's only one paper, not much. Okay.
Sure.
Sure. Yeah, the 3 minutes is yours. You scroll it down.
Yeah.
Okay, so I will just 1 minute. I'll just double check that the recording is working. Yeah, recording is working. Yeah. Yeah. Are you happy to start?
Yeah. Good morning.
Yeah, good morning.
I'm Dr. Satwat Mohit from the surgery. Am I speaking to Jack English's dad, son? I mean, I'm sorry. Am I speaking to Jack English's father,
Oh, yeah, doctor. I'm Mr. English.
Mr. English? Uh, um, how may I help?
Oh, doctor, I spoke to the triage nurse and I told her, Jack have, knee swelling and really I'm worried about it, about that. I hope you can help us.
Sure, of course, why not? So we'll definitely talk about this in a bit more detail. So can you tell me what's going on, Mr. English? So Jack has been complaining about his knee swelling.
Oh, yeah, doctor. Yeah, he's having knee swelling and it's painful now.
And can you tell me a bit more about which knee is involved?
It's in the right knee.
It's in the right knee. And how long has it been going on for?
Well, to be honest, the pain in the right knee has been lingering for around, I think 6 months or so, or 5 months. And we came from before to your one of your colleague, and he just tell us it's growing pain, and because he's 10 years old, and he will go out of it, when he become a man. And it's just the things are never settling down, and it's worsening now. And then from 3 4 days we found this swelling coming out, and I'm a bit worried, to be honest, and even his mom is worried.
Yeah, I can see it is definitely a difficult situation, Mr. English. May I ask, where is Jack at the moment?
Yeah, well, he's he's with the football team. He's keen football player. So
Okay.
today is one of his sessions. So he's there, although he's struggling from the pain. But I couldn't let him sit in the home. He's telling me, no, I need to go. It's very important. He's preparing, I think, for an important match. So I couldn't
Yeah,
let him to sit off. Yeah.
yeah, I think that was a fair thing to do if the child wants to go and join his friends in a match, and if he's able to do so, he should be allowed. Okay, now to come back to the right knee pain and swelling, which, if I summarize, has been going on for since the past 6 months.
Yeah.
And since the past few days, you noticed a swelling come up around the knee.
Yeah, doctor.
Yeah, I can see the picture that you have sent in, and thank you very much for that.
Yeah, welcome.
So yeah, and on the on if we compare the right with the left knee, so Jack has never complained about pain in that knee. Am I right?
In which knee? The right? No, the left knee. He did. No, there is no pain in the left knee. It's always in the right one.
Yeah. Okay. And this swelling, Mr. English, I mean, I would definitely want to see the child in clinic and examine him. But can you give me a bit, a bit of knowledge? I mean, how does the swelling feel? Is it hard or is it soft?
To be honest, it's a mix of both. So I can feel, like some fluid underneath it, and but also when I press, first it's painful. The second, I think there is some bone there as well.
Okay, okay. And I mean, the picture isn't very clear. Is the swelling towards the side of the knee, or is it in the center, just below the knee?
It's just below the knee, and then it's in front. Okay, where the chin of the leg. So it's on the chin of the leg, over the
Okay,
chin bone. Yeah.
it's on the chin. Okay, okay. Now I understand. So how much does Jack say is the pain on a scale of 0 to 10, 10 being the worst pain ever?
It varies, to be honest. Sometimes it's just, one or two, and we'll just go
Okay,
with some paracino or calpal. But
okay.
sometimes is especially after the match, it's horrendous pain. We need, to put a lot of ice. We need, to give him like ibuprofen, Nurofen, and sometimes we are putting gel as well. So it's not constant, to be honest, doctor.
Okay. And with the pain, I mean, is he able to sleep at night?
Oh yeah, well, it's not affecting his sleep much. It's sometimes
Okay.
he would wake from sleep, but in last 6 months, maybe that happened once.
Okay, excellent. I mean, at the moment he's gone out to play a match with his friends, which tells me he's active and about. And how is his mood?
His mood is fine. He's just annoyed because he feels that the pain is just holding his talent in the football.
Okay,
Yeah,
okay.
just he feel that there is a lot of moves that he want to learn, but he can't do it because of the pain. That's only, but his mood is general. He's a happy child, especially, after we started this medication, Concerta, I think,
Yeah.
for his ADHD, he started, to become more clearly thinking and more happy child, to be honest.
That's very good to hear, Mr. English. I mean that we are seeing him moving towards a more positive um, um, uh, towards a more positive end. I mean that it seems to be affecting him more positively, isn't it?
Yeah,
the,
doctor,
the,
yeah.
the medication. Okay, so from whatever you have mentioned, I mean, in a nutshell, he has been having this swelling and this pain in the right knee for 6 months plus, and now since the past couple of days, you feel a swelling just below around the chin of the knee. There's a semi-solid and a soft swelling. Yeah.
Yeah, yeah, doctor.
Yeah, okay. And from whatever you have mentioned, Mr. English, I feel that this is of what we know as a condition that we call Osgood Schattler's disease. Have you heard about that at all?
No, what is that, doctor?
So it's a condition, Mr. English, where the yeah there's a bony provenance of the bone of the leg. The bone which we know as tibia, its upper end has a prominence, the tibial tubercle, and that tends to become prominent and at time painful as the child grows.
Okay,
Yeah.
but why is that happening, doctor?
So it sometimes happens, and it is seen a few times in children who are active and participate a lot in sports. Yeah. At times we see that it happens. It involves both legs, but it can happen on one side as well, like in Jack's case.
Okay, but so it's not a cancer, doctor, because to be honest, me and his mom was worried about cancer.
Okay, so I mean that concern is for parents like yourself is very valid, and I did meant to ask you, but can I ask you a few further questions? I mean, is he achieving his milestones on time?
Yeah, doctor, he's achieving the
Yeah,
milestones. Yeah, yeah.
and has he lost any weight recently?
Yeah, to be honest, we noticed that he's losing massive weight, to be honest, doctor. Uh, he used to
Okay.
be a heavy child. Now he's losing weight significantly, but I'm not sure why, although he's eating good.
Okay. And is he does he have any night sweats at all?
Not particularly at night. He's sweating all over the day. Also, that's not we noticed that recently.
Okay. Okay. So I mean I mean the first thing we need to do, Mr. English, is to see Jack in clinic. Yeah.
Mm-hmm.
Once we see him in clinic, and examine his legs, we'll be able to shed more light upon on that. And then I mean as I said, it can be Oscar Shetler's condition, or you are concerned about cancer. We can look further into it, given the fact that you said that he is significantly losing weight.
Okay, doctor. Yeah, so there is a chance that can be a cancer.
So Mr. English, this is a slightly, I mean, it's difficult to say whether there's a chance of the swelling being cancer or not. However, we will investigate, and with blood tests, and if necessary, we can always X-ray the leg and go on from there.
So what blood test you would like to do, doctor? What blood test we will do for him?
So when he come, if possible, and you can bring him in today evening after his game. I can review him, examine him, and our nurse can do a series of blood tests, including full blood count, inflammatory markers like CRP, his liver and kidney tests, thyroid and glucose as well. Yeah.
Okay, doctor. And so if that is Osgood's Schlatter, what Osgoodson disease, how we can treat it, doctor? Is it treatable?
It's very treatable, Mr. English, and we don't need to do anything about it. The child just grows out of it and with time.
Okay, your time finish, but so anything you will say upward, you won't take any mark on it, okay? But you tell me what you want to say
Uh,
after
um,
that.
uh, I would, after doing the investigations, I would want to safety net
No,
the
no,
child.
yeah, yeah. So tell me, I am the father. Tell me, I'm just telling you
Okay.
anything you will say now, so you will know that you are losing mark now. Okay, so what you didn't say, you will lose mark for it. Okay, so what if any additional point you will say it now, you will lose mark on it. Okay, it's not a positive. Okay, so just what you will say now is just for you to know next time. You need to say it on time. Okay, anything
Yeah.
you didn't say it on time, gone. Okay, you won't take anything for it. Okay, so what you want, so continue your consultation with the father of the patient. Okay, so doctor, you said that he will grow out of it.
If the diagnosis is Osgood-Schindler's disease, the child usually tends to grow out of it with time. However, we intend to do blood results, and depending upon my examination, we can also do an X-ray of the leg. Once, and we can always do a follow-up, say in another week or two time, to go through the blood results to assess how the child is doing, and go on from there.
So what about the pain, doctor?
Yeah, now for the pain, I would suggest you continue doing what you are doing. At times, the pain is not much, but sometimes when he feels a lot of pain, we can always give Nurofen and Calpol.
Okay, doctor. And do you advise him to continue the exercise, or what do you think? Shall I let him continue playing football?
I think yes. If he's able to tolerate the activity, he should be allowed to play his usual sport.
Okay, okay, doctor. Is there's any drawbacks of that disease?
In what sense are you asking the question?
I mean, can any complication happen?
Uh, So once again, a tricky question, Mr. English. I mean, it depends upon what the underlying condition is. So let's see him in clinic, and then we can go on from there. And then I'll be able to answer more of your questions.
Sure, doctor, sure. So do you want me to bring him today?
I mean, they'll be really appreciated, so that we know what actually is going on with the child.
Sure, doctor, sure.
Okay, see you till
Okay,
later.
sure, yeah, sure. Thank you very much. So well done, you get the diagnosis right. So you told me what you think. If you repeat the case, would you do something
तुम्हारी
different?
हिम्मत कैसे हुई सब कुछ करने की?
Hello?
Yeah.
Yeah, so would you do anything different?
Yes, Dr. Slim, I think I started. I mean, I didn't start off in the right manner. There was a lot missed in the consultation. I
No,
didn't
no,
take a
don't
proper history.
don't be so negative. Well, you get the diagnosis. So say first the positive things that you did. Don't start with the negative. This is the first thing. Yeah, please, someone else if Dr. FN, can you just put your mic mute? Okay, we will open the discussion later on. Don't worry. Any one of you will have a discussion, will participate. I can see someone raising his hand. We will participate to just finish the discussion with Dr. Uh, Primary Care. Yeah, I promise everyone will participate in the discussion, but let's first give the feedback for Dr. Satwat, so Dr. Satwat can, can benefit. Yeah, she participates. She was brave enough to, to help all of us to learn from the case. So we need to listen to her feedback. Okay. So Dr. Satwat, hello.
Yeah.
Yeah, so always when you are studying doctors, never start with the negative, okay? Always look at at the glass and the full part, okay? Don't look at the empty part, yeah. The empty part will come, at the end. So what you think you did good, and then we will discuss, and then you will tell me what you think you can do it better next time. But you didn't do something bad, okay? There is nothing bad. Since you sacrificed your time to come to attend to learn, that's nothing bad in this. Okay, so never be negative, Dr. Safar. And
Thank
all the doctors here, never look at the negative part of your life. Always look at the positive part. Yeah, you are a doctor. Okay, you are in a training. Okay, training that if anyone else at any part of the other world will pay thousands just to go to be engaged in such a training. You are not paying anything. Actually, we are taking money for being a GPs. Okay, there might be some difficulty in your life, yeah, and that's life. Okay, life is never bread and butter. Sometimes up, sometimes down. You might fail one or twice or even thrice your exam, but this is not the end of the world. You are not, you didn't lose your hand, you didn't lose your eyesight. Okay, so always look at the positive side of it. Okay, not the negative side. So what you think you did good in this case, and then we'll discuss what you did better, what you can do better in the next time. So what do you think you did good?
So I think I started out started with housekeeping, which was fine. Then I just jumped onto the pain and the swelling. I talked I try to take an appropriate history to make the diagnosis, but and then I mean, I made sure that I was empathetic with the father, and I took him with me through the discussion. I chunked and checked. I understood his understanding at every point.
Mhm.
And Yeah, then I gave a diagnosis, and I meant to ask. I mean, the data gathering was not nicely done, and but I
Can no
went.
no 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 can be better. Okay, don't say not nicely done. Please, I want you to repeat that. Okay, this is the learning point. Okay, Your feedback is you are wiping yourself, and that's not good. Okay, so your history taking can be better. It was not good. Can be better. Okay.
Thank you, Dr. Slim.
Yeah.
And then because when you the father asked me, we are concerned it might be cancer. Then I said I meant to ask earlier on about weight loss and which I asked at that time, and I did not just did not justify going forward that since the child is going through a growing phase. And his height is increasing, so thereby a loss of weight, and he's an active child. Thus the weight loss. I should have
Yeah.
justified
Yes. Yeah. Right. See.
the
Yeah.
father's concerns.
Yeah, you are right. So see, with the second thought, you did recognize that might be the weight loss something logical. Okay, yes, he's active child, he's growing. It's normal to lose some weight, and the most important, he started on Concerta. Yes, he's ADHD child, and he started in Concerta. It's normal to lose weight. So Concerta is type of amphetamine, isn't it? Yeah. So
Yeah,
amphetamine, 30 years ago, the doctors was prescribing amphetamine for, for the beauty context to lose weight before going to the context. So it was a drug used for weight control. So it's normal. And then even I will see that in the PowerPoint, even in the when you start the patient on Concerta, the children, you need to do follow up for weight for their weight, isn't it? Every
yeah,
3 months or every 6 months according to their age. So that's a point that you need to raise in the patient management, because this case, the complexity in that case, yeah, there is some concern and musculoskeletal problem, but also there is a missed follow-up appointment. So that patient started in Concerta, and we have his baseline blood, vitals, the weight and the height, and he started in the medication, and then we cannot see any follow-up. Okay, according to the shared management policy between us and the primary care and the secondary care, that patient should be under our supervision for blood and and height, and then and inform the specialist with it. There is no any input from there. And the other concern that the other the other doctor, other locum GP, he said that is. A growing pain, yes. Growing
yeah.
pain cannot be unilateral, it should be bilateral. So this is another concern that we need to raise. So this is what you can just pick up from just reading that before discussing with the father, the patient father. Okay, so this also should be endorsed. So I can see it's a growing pain is less likely to be growing pain because it's only in one knee. So I think it's also good strata. I hear that you're saying that it's maybe a cancer, but I don't think it's cancer. Your child is active. He didn't lost appetite. Yeah, I do appreciate his sweating and he's losing weight, but I can't, but I can have explanation for that, which is the start of the for the ADHD drug, which is the concert. And by the way, we need to double check his weight. And so when you come here, we need to do all of these, necessary investigation. Yeah. So what else you would say it differently? Would you do anything different?
Yeah, I mean, I did not ask about any psychosocial.
Yes, no psychosocial. I didn't hear ICE also, I volunteer, okay, to tell you that this is my concern, but I didn't hear
Yeah.
what's his ideas. I didn't hear what's his main concern, or I didn't hear what's his expectation from you to do. And if you ask me, I will tell you I want you to do an X-ray, which you volunteer and you said, okay, we will do X-ray, but do we need an X-ray in Osgood-Schlatter disease?
No,
Um,
we don't.
okay, yeah,
It's
so we
only clinical
don't.
examination.
Yeah. No, sometimes we might do it. We might do it if the patient, if we have suspicion of cancer or we have suspicion of different diagnosis. But if we are clinically, 100% sure that this is Osgood Schlatter, then You don't need to do an X-ray. X-ray will be harmful for that child. Okay, the incidence of leukemia and thyroid disease because of X-ray in children is high. So don't just do X-ray because you want just to protect your back. No. If it's indicated, do it. If not indicated, don't do it. And in 90%, 99% of patients with Osgood-Schlatter disease, they shouldn't have an X-ray. So see, so there is a lot, well done for getting the diagnosis. It's just what I want also to hear from you, some differential diagnosis, because that's why, your history taking or your data gathering was not, was good, but not good enough to have, a definite diagnosis. Yeah, the idea in this exam, or the idea even in your clinic, is not just to reach the right diagnosis. You need to show to the examiner, or the one who's hearing you, or the one who's learning from you, that you have a thought process in how to reach the diagnosis. If you didn't show this thought process, well, you will not get enough marks to pass. Okay, so and one of the most important thought process is that you have some differential diagnosis, which I couldn't hear, to be honest. So, but I know that most probably but because maybe the topic is not common, I'm not aware that anyone, anyone else maybe discuss it around, and so I think it's a new topic to be discussed, but it's common case in real life. It's very common case in real life, and can appear in any exam, as I feel. So that's why maybe there was not thinking about, what other differentials. Well, although it's very common in the system, when you look at, the diagnosis, when in EMIS or System 1, you will find what is called anterior knee pain syndromes. Okay, so what's your differential of anterior knee pain syndromes, especially in children? Because always my supervisor, when I was a trainee, which was always telling me, don't put a definite diagnosis when you come when the patient come with the knee pain. So they always put anterior knee syndrome. I think, why? Well, I'm sure that is an osteoarthritis. So we never know what will happen in the future. So you have the capacity of putting a diagnosis of anterior knee syndrome. So, but what are the differential of anterior knee syndrome? And such incidents and that's child, what you think, what other possibilities that you can put it in your differential, and then hence you will be able to know what else you need to ask for that patient.
There is another entity, Dr. Slim.
Mhm.
I,
Yeah,
I,
chondromalacia. Well,
con,
chondromalacia, yeah, chondromalacia. So see, so chondromalacia is one of the anterior knee pain syndrome. So what chondromalacia? What the patient will present with? Or
Controversial.
osteochondritis, yeah, which osteochondritis dissecans. This is the fancy name of the kneecap.
Yeah, it's usually when when the child is kneeling on the knee.
Yeah,
That's when
also no, kneeling, yeah, kneeling on the knee can make anything. Can make Osgood-Schlatter, can make osteochondritis dissecans, can make can make the anterior cap or anterior knee bursitis, which is made knee. Also, I don't like this terminology, which is knee made knee. Okay,
yeah.
which I don't like this terminology. Yeah, that can be. So kneeling can cause all of that. What else? So how you will know? So how you will know what is the how you will diagnose the osteochondritis dissecans? Which basically, so for the doctors that is, it's the cap is the kneecap or the patella, having a joint between it and the femur and the tibia. Okay, so if this joint is inflamed or having osteoarthritic changes, that's called the osteoarthritis dissecans. So what will be the question is open for all doctors. So how the patient will present if he have osteochondritis dissecans? Anyone knows, doctor?
So it's basically Dr. Slim, the cap of
Mhm.
of the knee, that's slightly mobile and painful.
Okay, so then the knee acts as a pulley. The cap acts as a pulley. So if this pulley is not working, so how the patient will present?
With the limp.
Limp or giveaway, yes, or giveaway, or sometimes it can come with was interlocking knee. Did
So
anyone saw a patient with locked knee? You know what's locked knee? The patient cannot flex or extend his knee, yeah, or give
yeah.
away. What else? What else in the differential?
Menisci problems, meniscal tears.
Yeah, yeah, but then and that how you will ask it in in this in your question trauma, yeah. Yeah, trauma. So any joint problem, you need to ask trauma. Yeah,
Trauma. Yeah, yeah.
you can't analyze, knee problems or elbow problem or hand problem, without asking about trauma. So he's a person that is doing a lot of activity. That does he had a trauma or not? Yeah. So
Yeah.
what else? Yeah, but the other thing, yeah, will be bone tumor. Then bone tumor will be, malingering pain, waking him from night, and constant pain. Okay, and then the other thing that you need to ask when you ask about any joint, you need to ask about the stiffness. Yes, if there is any joint stiffness, does he have a joint stiffness or not? Also, I didn't hear that, so you need to ask about the stiffness, and then according to the how long the stiffness is staying, you can say this is an inflammatory disease or this is a mechanical disease. Okay, so if it's mechanical, osteoarthritic, or even osteoarthritis can, so it's usually the stiffness in the morning and will subside after 30 minutes, and then if it's staying more than 30 minutes, so it's autoimmune inflammatory disease. Okay, what else? Can be vitamin D deficiency, can be making bone, a little bit deformed, well, can be. And what else? Infection, osteoarthritis, septic arthritis. This is also one of the, so you need to ask about how's the patient systemically. Does he have a fever? Does he generally find, obviously he's going to play football, so most probably he's fine. What else? What else? Something very important in the children, and you should not miss it. Specific in the children. Anyone can know? Something beginning with juvenile.
Rickets or
Rickets,
arthritis.
rickets is part of vitamin D deficiency, but I
Yeah,
didn't see
yeah.
rickets in this country. It's very difficult to find rickets. Back in our countries, yeah, we can see rickets. Okay, I saw a lot of rickets in back in Egypt, but here because of the malnutrition and people are not well educated. But here the children, especially children in this country, they have very good safety netting around them, and that's very good. That's very good to be in such system. Okay, there is a
GRA,
good care. Sorry.
juvenile rheumatoid arthritis.
Yeah, not rheumatoid. Rheumatoid arthritis can happen in children for sure, but the
Yeah.
juvenile idiopathic arthritis. Do you know? Do you have any thoughts about how he can present, or what you are looking at?
They will have acute inflammatory joint pain and
Yeah.
swelling with fever, heart murmur,
Uh-huh.
sweating, and they will be acutely unwell sometimes.
Yeah. And what specifically when you examine the patient you would like to look at?
They will have joint swelling and they
Mhm.
will have high fever, heart
Mhm.
murmur, and sometimes rashes will also be there.
Yeah.
And
Something important. Once you find it, you need to tell him go to the hospital now. No wait for me. Uh,
okay, heart rate will be high.
generalized lymphadenopathy, and then
Generally, oh
yeah,
yeah,
yeah, and then
yeah.
generalized hepatosplenomegaly. Okay,
Oh
so
yeah,
these are emergency. That's need. So one of your things that you when you bring him in, so because you won't take if you said I will bring you for examination, you won't take a mark. You won't take a mark. You need to say what you will examine. I need to examine his knee. I need to see if there is any lumps or bumps. I need to feel his stomach to see if there is any, enlargement or, in his organ. Okay. And that will, will show that you have a differential. Okay. Um, so I hope that, this differential now is fine. Then in any joint, you need to examine joint above and joint below. That's a rule because the pain can be referred. So you need to ask a little bit about the hip, if there's any hip pain, and then a little bit about the ankle pain. So in the hip pain, what might be the cause, and it's referred to the knee. Also important for pediatric cases.
Developmental dysplasia.
Yeah, you are right. And what else? Because developmental dysplasia usually will be in younger age, okay, and
In
these
younger
are
age, yeah.
important in
Sufi.
yeah, Sophie, yes, exactly, yeah, which is the slipped upper femoral epiphysis, and usually the patient will be shoppy, and maybe having also history of hypothyroid or something like that. So that's important because also one of the things that you need to also to be aware about it might come also in your exam or even in your real life if the differential of a limping child. So limping child can come and say, oh, my child is limping, so Sophie is one of the differential. And then again, juvenile idiopathic arthritis is one of the differential, and osteoarthritis, septic arthritis is one of the differential. And be aware about what is Kocher criteria of diagnosis for septic arthritis, which is no weight bearing, high white blood cells, and fever above 38 or 40 degree. Okay, so that's what these all need to be asked, doctor, in your in your data gathering. Okay, I hope that maybe put better better and a better way of it will be better way for you next time when you do the case. What I notice also, Dr. Sat, what you are doing a lot of micro summary. You did micro summary 2 or 3 times in your data gathering. That's you don't do micro summary. I'm not a fan of micro summary except if if in 3 situations. Okay, first you need to do it before the management. Okay, just to gather your thoughts. So because if you have if you have you are not aware what I should do in the management, is there is any problem, um, I missed I don't have enough data, then I will do micro summary. Maybe the actor will give me, an additional information. Okay. Or if I do, if you have a lot of time, it's 12 minutes and you finish all your questioning at 3 minutes or 4 minutes, then you have a lot of time. Let me do micro summary. Maybe I forgot something there. But the third time, if you are becoming panicky and and you cannot control your nerves, so do micro summary. That will make you calm down and make your thoughts more organized. But keep losing your time by doing a lot of micro summary. That will, definitely will not be able to finish the case in time, and then they will downgrade you and in the time management. Okay, and will shatter the way, because the way of your the way how the conversation or the consultation should go should be conversational consultation. So it should be one-to-one consultation. You are talking, patient talking, you are talking, patient talking. But keep micro summarizing will not be helpful. So please don't micro summarize except maybe in these 3 cases, or if you are a fan of micro summary, so just do it once. Okay.
Yeah.
Then be aware by the opening statement. Your exam can be in the morning, your exam can be in the evening. Okay. So don't always, when you are practicing, will say good morning. Okay. Because it might be not morning, can be evening, isn't it? So we are actually good night. So take care. Okay. The other thing, don't say how can I help you. You have half A4 paper there. Okay. You already know that the patient coming with knee swelling. I can and pain. So just tell him, okay, I can see you're coming for knee pain, and also I can see that John or Jack started on some medication, new medication. How is he with the new medication? They didn't give you information in your they in your sheet for nothing. So you need to be able to use each of these information in your 12 minutes. Okay. So the 3 minutes of reading is part of the exam, okay, is part of the consultation. So you need to analyze, think how to utilize all the information in front of you in your management plan. Okay, so if they give you that he was having having AHD and having concerta, you need to use it in the management, okay, and mention it in your talk with the patient. If they said that he was seen by another colleague from 4 or 5 months and it was a growing pain, you need to mention it in your management, okay, or in your consultation, okay. So you need to use all the information that the examiner will give it to you. Is that clear?
Yeah.
Okay. So, and then in the management bit, I'm against you, to be honest. Okay, you said Osgood Schlatter, but how you would anyone know how they can explain, or if you want to explain it again, how you can explain Osgood Schlatter syndrome? And we will explain it in details, by the way, by photos and so because we need to understand the Osgood Schlatter because it's common, okay, and you will see it sooner or later. You will see it in your practice. So, how you will explain it to the patient because that's important. Any doctors? No, any doctors can help in an explanation of Osgood Schlatter. Any doctors can unmute himself and tell what Osgood Schlatter is. So it's traction injury. Okay, when you explain to the patient, tell him the soft part of the bone, or which called the end plate, which the growing part of the bone. Okay, and the tendon of the muscle that is in front of the thigh is attached to it. Okay, and because of the continuous traction, especially your son is a keen sporter, so that continuous traction on it can cause the injury and inflammation on this, soft bit on the growing part of the bone and present with such symptoms. However, it's very common, okay, easily treatable. Okay, so what is the treating points? Because for sure it's not just the patient will grow out of it, and because if you said the patient will grow out of it and then the patient had a complication, then this is a big problem. Then it will be your responsibility. So what will be your management? You know that in that exam the management plan have the higher mark until now. So at least you need 5 6 points to put it in the management, and for sure not one of them the patient will just go out of it. You need to say something. Okay, you need to address the concern. Okay, the patient saying, okay, it's less likely for sure to be a cancer. However, come and need to examine you. Okay, but then if I say X-ray, will say no, you don't need an X-ray. It's clinical diagnosis. But then, what you need to say more, or how you will explain to the patient why you have it now. Why now, doctor? Why the swelling start now? You,
Since
you,
the
you, yeah, because you explain it. You explain it some in between the things, but so why the inflammation is happening now? Why we are seeing the Osgood Schlatter in the growing bones? Why we are seeing it in the in 12 to or 15 to 16 to 18 up to 18? Why?
because at this stage the bones are growing. The child is
Okay,
active.
and then
Uh,
so if the bone is growing, so what is the problem? If the
So
patient is growing, why especially in that age group, you know, these traction injuries will start to appear because it can happen in the knee, can happen in the the heel, can happen in the elbow, and each one of these have different name, by the way. So we have Perthes disease and Sieve disease, and there is a lot of diseases like that. So it's not Osgood. That's why I bring Osgood Schlatter because it's the most common. Okay, but there is other apophysitis. It's called apophysitis because the apophysis is the part of the bone where the tendon of the muscle is attached to, okay, at the end plate. So, and we'll see that in photos. But so this epiphysitis, why it's happening in that age group? You know, I will explain. Maybe so part of the physiology when that happened. The growth spurts. The bone lengthening, is outgrowing, out fast the lengthening of the muscle and the nerves. So, the bone is growing first, and then the muscle is stretched, and then by time it will grow. So the muscles and the tendon will always be in a state of stiffness, and the traction injury will increase at that age. Okay, that's only because the bone is growing faster than any other part of the body. Okay, and that will make the muscle, stretched, and then, the traction injury with the repetitive movement will happen. Okay, Uh, and that's why one of the method of trying to treat the patients, first, for sure, pain management, pain management, pain management. Okay. Second thing is rest, but not inactivity. You can't tell him don't do sport, but you can ask him what is his sport schedule. Then I will tell you, that patient will tell you he's going for football matches for 6 times a week. No, you cannot go 6 times a week. Okay, so you cannot pull him out of the football as well. You cannot just destroy his dream by being maybe a famous football player. Okay, so just tell him we need to decrease the activity of his playing. Okay, so instead of 5 times or 6 times, let's go 1 time. Okay, then he will, the father, because all of this I was planning to add it as a layer of complexity to, so you can answer me. Okay, so the other thing that I was hope, okay, doctor, will he have an ADHD? And actually, we depend on him to play sports to make his activity less, and to make his attitude calmer and behave more adequately. So what we should do then? He told you, if any other activity, then we can tell him, okay, I will refer you to physiotherapy. Okay, and also we can find another activity for him like swimming. Okay, swimming is very important and very good for such cases because it doesn't put a load on the knee. Swimming, okay, so you can guide him for swimming. And then the physio, why they will do massages, stretches, and teaching him to do stretches to the muscle, and that will help with the strengthening of the muscle. And then when the muscle become elongated, okay, and the tension less, that will decrease the traction on the cartilage part of the bone, and the symptoms will improve. Coming back, what are the complications? There is complication. Yes, there is complication, but this is your red flag. This is your safety netting. Okay, so don't expect that something will appear in the exam, for example, from what I'm seeing, because anything can appear for sure in the exam, but from my understanding, okay, there will be something to do safety netting for. Okay, so always think about, does this disease I can safety net for him? Okay, shall I safety net him for cancer? You can safety net for him for cancer. If you have, night pain that is waking him from sleep, if you feel any lumps or bumps in his body, I need to know. The other thing, what can happen in that patient if he didn't stay, if he didn't have rest, if he didn't listen to you and keep playing, what are the risks that can happen? Anyone can participate in that? I'm sure doctors. I'm sure without doubt, what can happen with the continuous persistent traction. That what?
I mean, the pain will persist and might become
Okay.
chronic.
Well, yeah, it can cause deformity. Yeah, you can have deformity. Okay, but player knee, there is something called player knee. We'll see picture in adults how this tibial tuberosity are prominent and ugly looking, perhaps. What else? Traction injury is considered as minor fracture. Then once, or maybe then we'll have a avulsion injury. Avulsion injury, so the quadriceps muscle is not attached to the insertion. Then that's a major issue. That's need operation to be fixed. Okay, so if the patient ignore and continue doing the activity, still you need to let them know that you might have avulsion injuries, and then this is a serious thing. Okay, especially in a child that's need an operation, that's need put him in a sleep, but major operation is not a minor operation. Okay.
Yeah.
One of the things that you might also consider asking patient or child's coming with reactive arthritis, does he have symptoms of gastroenteritis recently? Campylobacter jejuni can cause reactive arthritis. and cause reactive iritis. So that's one of the things that you might consider asking. So a lot to ask. Okay, here again the recording. Okay, and I'm sure when you do it the next time, you might also do it with your colleagues, and that's will make you kneel in the information that you learned today. Okay, and blood wise, the only thing that I would do for that patient, vitamin D, to be honest, okay, unless when I examine him I find something else, X-ray not needed, and then just follow up maybe after a month or so, because it will continue. That will not stop unless the patient become a man, and the all the epiphyseal plates closed, and that will happen in puberty when at 18, 16 years old. So it will be there, so you might consider following them up. And the other thing, don't forget to address the shared management plan of the concerta. Okay, and the differential of the growing pain, because not every pain in the child is a growing pain. I will now share the PowerPoint. Let me close that, and then the PowerPoint will have more will have more information that can help us to understand the situation of that case. Does anyone have question before going to the PowerPoint, and anyone want to add anything from the doctors? No?
Hi, can I
Okay.
ask a quick question?
Yeah, go ahead, doctor.
I was just going to ask about the how to differentiate this from an osteosarcoma, because when we were reading the initial page, it said that the pain was waking him from sleep.
Yeah, but when you ask the father, he said he wake him once in 6 months. If it's an osteosarcoma, it will wake him every day. Okay, osteosarcoma is not an easy pain. Okay, and I hope you will never see someone with osteosarcoma, because it's a devastating disease. Okay, it's not an easy one. Okay, so osteosarcoma every day, night sleep. At first it will not be only on night; it will be all the day, but then at night time it will be, much more. Okay, and it will not be once in a blue moon; it will be every day. Yeah,
All right, thank you so much.
yeah, no problem, no problem. Anything else? Nope. Okay, what you need to ask when you have a patient or child with musculoskeletal is called, most of it you already asked it. Okay, so how his general health? Okay, and the red flag, as we say, it's night pain, bone pain, fever, anorexia, and weight loss, and malaise. Okay, also how it started. Okay, as Dr. Satwat asked, how did it started? If there's any trauma or reactive causes, like gastroenteritis that will cause reactive osteoarthritis. And then the other thing, what are they like in the morning? Okay, is it mechanical or inflammatory? And we say the mechanical pain will be on the first half an hour, and then the inflammatory pain within the 45 minutes, or will be more until it's clear. Okay. And then the associated symptoms as well, if you have skin rash or not, okay, have any constitutional symptoms or not, and then the general development. Okay, what can they know? Also, what can they no longer do? Okay, what's the effect of the pain on his life? Okay. Uh, uh, these are the definition of on our of Osgood Schlatter, or how it can happen, and I will show that in the photos. Okay, that with traction injury, so we can see the quadriceps muscle, because the bone, okay, will grow faster, and then that quadriceps muscle will be in a state of tension, and then with repetitive movements, the epiphysis here will be, in continuous traction, which causes minor fracture to the epiphyseal end the plate, and then that will be healed by inflammatory process, inflammation, just to try to limit the movement and try to heal the cartilage, and then with the repetitive movement that can having avulsion fracture. and I will show some picture of avulsion fracture in front. Okay. There is another, syndrome, okay, which is Lurzen syndrome, which will be the inflammation in the opposite side. So instead of where the quadriceps tendon attached to the tibial tuberosity, the quadriceps tendon, when it's attached to here, to this, to the patella from the lower part of it. So the pain either can be not here, can be here. Also, that's something called Lurzen syndrome. Okay. What is important here on this, okay, is just no activity, okay, no activity. Please don't tell the child I will not stay home and don't play, okay, because he will tell you I will never, okay, I will never let my Ausgabesvater slow me down, and it will be a fight between you and the child. Like the age where it's happened, average 10 years, okay, 10, 14 boys, and then 8 to 12 in girls, okay. And what are the clinical features? Usually unilateral, very rare bilateral, and then it's a gradual onset. So it's been, there happening for 6 months, okay, where he's coming to the doctor single, and he said that he have a growing pain. So it will be gradual onset, not sudden onset. Okay, and it's not continuously painful, it's intermittently painful, okay, especially with the activity. And then you might feel the tubular tuberosity will be tender or maybe not, because if it's not tender, mean that the disease is not active. It just make deformity, but if it's active, you will find it painful, and that will give you a hint that patient need to have a rest. Okay, the stretch therapy should not be started except when the pain gone. Okay, don't start that stretch therapy with the physiotherapy when there is pain, because you will put the bone in a stress, and that will not make the bone, easily healing for the bone. Okay. Uh, X-ray not needed, as you said, except if you have, clinical suspicion. Okay, and these are the differential, bone tumors or infection, osteoarthritis, and that will cause you night pain and then wrist pain and constant pain, not only during night, it's all over the day. And the juvenile idiopathic osteoarthritis or arthritis, we said lymphadenopathy and hepatosplenomegaly, and the patient will be clinically ill. And then don't forget if the pain is referred from the hip, either reactive or Pear's disease, or SOFA, which is slipped upper femur epiphysis, trauma, and osteochondritis dissecans, as you said, it can give away a looking vitamin D deficiency. Precipitating factor, heavy contact sport, vitamin D deficiency, and as we said in the pathophysiology, that's tension of the muscles. Management, okay, as we said, pain, okay, ibuprofen, okay, paracetamol, ibuprofen gel, okay, don't forget the ice packs, okay. Are we applying ice directly to the skin, doctors? How you will say to the patient, apply ice? Anyone can participate. How you will say to the patient to apply ice?
So, Dr. Slim, there are nowadays ice packs available.
Yeah, I'm with you. Yeah, ice packs. But then if the patient don't want to buy ice packs, so ice packs,
So
how much it will be? It will be 10 pounds. Is it 10 quid? And 10 quid, he can go and buy, some food for his children by it, other than. So how he
so,
can use the food? How he can use
uh,
the food in his fridge to how to use an ice packs?
I think that needs to tell them that you can wrap the ice, the pieces
Yeah,
into the towel, and
yeah,
avoid the direct contact of the ice to the skin,
yeah, yeah.
and then leave it
Yeah,
for 15 minutes, and then do it for 3 to 4 times.
yeah. But there is better than the ice, because if you use the ice will melt, and it will make will make water everywhere. What else?
Peas,
Yeah, exactly. Chickpeas. Yeah, peas. Okay, peas, frozen peas. Okay, with it already the frozen peas in a bag. Okay, so just frozen peas, wrap it with with a towel and put it underneath. Okay, don't avoid direct ice contact to the skin, because that can burn the skin. Okay, so you don't want to have forced bites. A stretch, okay, and a stretch of the muscle. Okay, that's the physiotherapy, and that should not be in the active stage of the disease. The other thing, insole shoes, because that will decrease, the overall pressure on the joint, and you can protective pads also can be, okay, and shock absorber. Okay, before doing the sport, you can apply, heat on the tendons, because that will make the tendons, less tense, and will make it more malleable to be, and will prepare him to do the exercises. Okay, and then the ice, as the doctor say, 15 minutes. Don't forget vitamin D, and then reassurance, but please not complete reassurance. Mention the side effects that can happen if he continue, playing in the same activity. Not put him off, but put him back little bit. Okay, not put him off, but put him back from his activity. Okay, and usually they go out of it within 24 or 2 years. Okay. Uh, that's an active disease. I will show you in a growing man or how the deformity will look like. Okay, that's just to know that. So the long bone have diaphysis, where the bone marrow is, and then the metaphysis, which is the cancellous bone, the spongy bone, and then the epiphysis. And the growing in the plate is the cartilage, which is between the metaphysis and the epiphysis. And we can see here there is an epiphysis and this part of the bone called the apophysis, where the tendon is attached. Okay, I will ask a question. Okay, and see how you are thinking, doctor. So, can someone tell me why the bone, why the muscles are attached always to the end of the bones? Why not in the middle of the bones? Why always the muscle is attached to the end of the bones? Why the origin and the insertion of the muscles are attached? You might find, part of the muscle attached to the bone, but always the origin and insertions of the muscles are always at the end of the bones. Why? Did anyone have thoughts?
The joints in between, there would be more traction. If the joint is bending, the muscle would be more stretched if they are in the middle of a bone.
Um, so if the muscle is attached here,
Hmm.
is less stretched than if it's attached there?
Because when it's going to bend that then it would be getting more stretched, and there would be a bend with in the muscle belly, which will
Bend in the
cause,
muscle or bend in the bone?
when the joint is bending, it would be pushing the belly of the muscle, and there would be more traction. There could be chance of more like local trauma or friction to the muscle.
Uh,
I think that it's pull on the bone. That is, there's a change in the angle at the synovial joint, which essentially moves the skeletal. You know,
Or
I'm
doctor,
I'm I'm with you, yeah. I'm
your
not yeah. Yeah, to go
Dr.
ahead,
Sim,
doctor.
the blood supply towards the epiphysis is far more than it's towards the center.
Well, the muscle have its own blood supply, isn't it? Yeah, some of it will have blood supply from the actually the bone have blood supply from the muscle around. Uh, so it's not the blood supply.
I think maybe it generate heat in the body to protect organs to help maintain the posture.
It will generate if it's attached to the end of the bone or in the middle of the bone.
I think it's for mechanical reasons. I think that's the most efficient place a tendon connects.
Mechanical reason, then the muscle, the mechanical reason only is yeah, there is mechanical reason, but the main mechanical reason is muscle should pass through a joint, so otherwise there will be no need for the muscle. So the muscle is connecting the bone and should pass through a joint. So the joint, you will be able to move the joint. Otherwise, you will not be able to move the joint. But then why the muscle is always at the end of the bone, not in the middle of the bone? Ah, to explain? Okay. So where is the growing part of the bone?
at the
At the end,
ends.
At the ends, yes. So the growing part at the ends, yes. So the bone is growing from here, yeah. So that will expand up, and from here that will expand down. So the muscle should be attached here. Otherwise, if it's attached here, it will be super stretched, and then it will become, torn, isn't it? But if it's attached here, the stretch will not be that much, isn't it? Yes or no? Are you convinced, doctor?
Yeah.
Yeah. And that's why when there is rapid growth of bone, and that's what the main issue in the disease, rapid growth of bone is is more faster than the growth of the muscles. So still the muscle will have some stretch on it. But just imagine if this muscle, instead of being here, it's here. So how much stress will be on it? How much stretch will be on it? It'll be massive. Okay, so it's always in the end plate. So the patient, when the bone or growth, that will, will give a chance to the muscle to catch up, like the growing end of the bones. Okay. That's the same, the same concept is just showing what are the part of the bones, okay? And this type of injury of epiphysis, it's not that important for GPs other than, maybe the Osgood-Schlatter, okay? Because still we can have fractures. It's one of the most difficult fractures, okay, to be diagnosed in the emergency department, to be honest, if the patient have Slaughter-Harris classification or Slaughter fractures. Okay, this is how it will look if you did an X-ray and the patient coming can see there is this, see this gap and deformity. Okay, this is an active disease of Osgood-Schlatter. Okay, and then we already explained that. I told you that a traction injury for the the growing part of the bone, but this is more wordy one. Okay, I think it will waste your time, but you can use it as well. Okay. Um, Yeah, so this is the complication. You can see the avulsion fracture. So the bone completely shattered, okay? And actually sometimes the patella also will be up because of the avulsion injury. And this is an adult, you can see he have like two knees, okay? He have like two kneecaps. So which called, the athlete knees, okay? Uh, that the problem with that not only cosmetic. Okay, the problem is that that can, precipitate to osteoarthritis of the knee early. Okay, we discussed that. Okay, the growing bone. So don't make the definition. The diagnosis of growing pain. An easy diagnosis. Okay, it's diagnosis of exclusion. So not every child will come to you. Will say, "Oh, you have a growing pain," because you might miss a serious disease. Okay. One of the rule. So this is the first rule. Okay, that it's a disease of exclusion. Okay, groping are common and may occur in up one-third of the children. The usual age is from 3 to 4 to 12, and the hours always pain is symmetrical, okay, bilateral symmetrical, and not and the lower limb and not limited to the joint, usually in the bones, okay, not in the joint itself, okay. And pain never present at the start of the day, so after waking up, the patient will be fine, and the child will not limp, so it will not cause mechanical discrepancy. And the physical activity usually not limited, okay, and physical examination will be normal, and the patient will have no systemic illness, and the milestone will be completely normal. Okay, that's only when you are able to say this is a growing pain. Okay. uh, when the other differential also you need to consider safeguarding. Okay, actually I need that to be discussed. So I need from you doctors to participate when you will be able to when you should suspect non-accidental injury in the children, because that's important. That's a safeguarding issue. So you need to be aware about it. What are some? Can someone tell me? Anyone can tell me any signs of fracture or injuries in the children that you would say, oh, this is non-accidental injury?
So when
So, Doctor,
the history and
the,
the injury is not matching up,
Okay, discrepancy, yeah.
if there are other sites involved, like old bruises, uh,
Uh,
oth-
Different age category, yeah. Different
different
age, yeah,
age and
yeah.
different category,
Mhm.
And if the family is overall cause of concern, like they are previously known for
Mhm.
any concerns about safeguarding, there are usually
Mhm.
alerts for such
Mhm.
families.
Mhm. Mhm.
Foster children being
Yes, what else?
So,
Yeah.
Dr. Slim, if there is a fracture or an injury in which is usually meant to be sustained by a walking a child who is mobile,
Would
but
you,
in
yeah, so if the patient is not mobile and have, fracture in a mobile,
yeah,
yeah, with you, yeah, so you cannot say the patient have 6 year, 6 months and you're saying he have fractured tibia because he fell down. And that's for sure. Yeah, you are right. What else?
and bruises in
Good.
places which are not easily prone to be subjected to falls.
Like,
For
like, like,
like for example, no, on his chest or
mhm.
on his thighs, on his arms,
Yeah,
on
that
his, on his torso.
yeah, yes, where they
Bruises
are grabbing, yeah, the grabbing injury. Yeah, what else?
in the buttock also.
The what?
In the buttocks.
Yeah, yeah, in the buttocks, one of the side that, yeah, in the buttocks, if they are hitting the child in the buttocks, where else?
On the head behind the ears.
Well, can be if he fall down, he can hit his head behind the ear, but well, where else you might consider it? If the patient have twist, have spiral
Twisting injuries.
fractures.
Yeah, spiral fracture.
Spiral fracture, because that's twisting injury. Okay, it's very difficult for the child, to have a spiral fractures because their bone is very malleable. But if someone make like this to his bone, that's mean that someone is torturing him. So spiral injuries. Okay, what else?
Frequent attendance for
Yes,
less
frequent
important
attempts.
injuries.
It can
For
be,
less
yeah.
important injuries. Yeah.
Mhm. Can be. Also, you need to be aware in such cases what shaking baby syndrome.
Yeah, and
Shaking baby syndrome, and
somebody who is not related to the child, like may not be the parents. Sometimes they will bring grandmothers or some other relatives, uncle,
okay,
aunt.
yeah, yeah, from the history, yeah, I got you.
Yeah,
Okay,
and they'll be dominating
frenulum,
the whole scene.
yeah, exactly,
They'll be
domination, yeah,
dominating the whole scene. Yeah, yeah.
yes, yes, yes. And then if there is fracture, if there's injury in the frenulum, this behind the lip, the frenulum also, that's not a place for child to be injured in. Okay, these are the main sites where you need, to think. So if you are suspecting and that there is a non-accidental injury, where you should look else also, other than these site, and make sure. And if you find an injury in them, most probably you will say, "Oh, this child is being hit." We're usually the perpetrator attacking the child. So in areas that, you know, is
His
difficult for.
genitals.
Genitals, no, he will not attack because mostly you will go and examine the genitals, and you find the problem in the genitals, you will be easily accuse him. But in areas that is not usually, if he make inflict an injury, will not be easily discovered. The soles of the foot and the palms of the hands. These are sites that's very not uneasy to show bruises, okay, because they have fascia. So hitting the child or an adult even in these areas will not be easily shown. Okay, but if if someone is hit it on his palm of the sole, it will not be bruised. Okay, and the other thing, or for sure, shaking baby syndrome. So if you have a child something like that, and you need to examine his back of the eye to make sure that he have no retinal hemorrhage. And
Sometimes
that it,
thermal injuries.
sorry.
Thermal injuries like burns,
Thermal
scars.
injury, yeah, but it can happen because sometimes the baby, especially if he ADHD, yeah, he's very active. Okay, sometimes can happen. For example, the iron or something in the side of the table, and he's playing there, and it will fall on him. So yeah, you need to be suspected. At least there will be some, the parents are negligence from the parents. Yeah, it can be, but also, with the ADHD child, you can suspect such injury. Okay. But if well demarcated, like, lower half separated from the upper half, like immersion injury, okay, and hot water or something, that's something you need to take care of it, okay. So all of that are important because you might be the first doctor who is seeing the patient. You might be the first one. They will not take him. Most probably it will be delayed presentation, so they will not take him to the emergency. So you need to be aware about the pattern of injury that can affect. Can be suspicious of of non-accidental injury. What I want to say, because if you notice that in children who are not using the BMI, you need to be aware about, how to read the growth chart in the children. Okay, and you know that if the patient below the fifth, below the less than the fifth centile is, usually having, low weight, and if it's above the 95th percentile, he is, heavyweight. Okay, so please be aware about the centiles. Okay, don't go to your exam without reading what is the centile, and it's very important in your life, because in your day-to-day activity, because you should fill in the red book. You need to know how to fill in the red book and how to use it, the centile of the growth of the children. The next time when you find a child with the red book, open the red book and just go through it. Okay, don't go out of your training without knowing how to read the centile and how to document on the centile, because the 6 week and for the 6 to 8 week check, you will do it. Okay, if you didn't practice to do it in your in your training, you will be in a big mess when you graduate. Okay, you need to know how to examine the baby. You need to know how to do Barlow test. You need to know how to check the hip stability. Okay, you need to know how to check the fontanelle of the patient. You need to know how to check the red reflex of the baby. Okay, don't go out of your training without letting your trainer to teach you these things. Okay. Coming to the shared management or the shared care of the ADHD medication. Okay, usually a patient below 5 years old, it's very rarely that they will start him in medication. They will use the parenting technique first, and then the school technique, behavior modification technique first, and then they will decide to give the child maybe after that the medication. Okay, what are the medication? Most of them are brain stimulant, and ephedrine derivative. The most common one is methylphenidate or the Concerta. Okay, and the methylphenidate is the first line treatment either in adult or in a children. Okay, we will take the ADHD in detail in one of the our teaching session. Okay, but not now. I think maybe in the next month, inshallah. What we need to know about the methylphenidate, that it's shared care management, and before starting it, we need to know baseline height, weight, blood pressure, and heart rate, and sometimes ECG if it's needed, especially if there is a family history of cardiac disease. Okay, and then what are the follow-up? So if the patient less than 16 or above 17, and then if it's less than the height should be 6 monthly, and then the weight, it depends on the age. If less than 11, then 3 monthly. If from 11 to 16, then 3 monthly, then 6 monthly, then every 6 months thereafter. Okay, in adult every 6 months.
So,
Heart rate and blood pressure 6 months. Yeah, go ahead, doctor.
Dr. Slim, for children, there should be a pediatric blood pressure monitor.
Well, we don't have in your clinic.
Or I haven't seen one. No.
Then I think we have. Okay, so maybe it's not in every area, but yeah, if you are, I'm sure if you ask the nurses, they will have. So next time when you go to a clinic, go ask the triage nurse, or one of the nurses. They will find the cuff that they are hiding here there. Okay, and they are using it for their patients. So just
Yeah.
double check. I'm sure you have. Okay. You cannot be not you cannot not have them. Maybe you don't have pediatric, the small what is the name? Weight scale, that for children less than 1 year. But I'm sure that you have a blood pressure machine, and for sure you have a pulse oximeter for children. But just ask. Well, maybe you didn't see it, but most probably they will hide one or two aside because it's not common to be used. So some will be somewhere, but it's your obligation to know where it is. Okay.
Thank you.
No problem at all. So that patient, you need to bring him to also to check his weight. If there is massive weight loss, you might consider, writing to the specialist, to the pediatrics, okay? And one of the tricks that you need to, to tell him, well, he needs to eat maybe, although he's actually the weight loss for that patient that we discussed was good for him because he was in the higher centile, so he's in 95 centile. But if it's the patient is losing more and more weight, then you might increase, his nutrition, calories, okay, or let him eat take the tablet in between the food, okay, and that will decrease the side effect of the tablet for by making the metabolism more, so it will make the side effect less. Okay, please, doctor, be aware by our SCA channel, YouTube channel. Please subscribe, okay, and share it. Share the knowledge with your colleagues, and let the people know about the teaching. Okay, and we have the WhatsApp group, okay, and Telegram group. I didn't activate it yet. It's there. There is like 40 or 50 doctors there, but still, I'm not making any activity. But there is a plan in the future for it, okay. And again, be aware that I'm giving, many mocks. I'm giving one-to-one teaching. If you need any help or support, I'm more than happy to support you. But January, for the January exam, I'm fully booked. So if you are in May exam, or if you are in the February exam, you will find some places after the coming exam which is the 8th from the 8th. So I'm free from the 8th of January. After that, before that, I don't have spaces. The other thing, the doctor who win the last competition is Dr. Milana Mihani. Okay, and the question was when we are obliged to use the ciprofloxacin in children, and then the answer is anthrax. Okay, that's the only, so anthrax or anthrax attack, you need to use the ciprofloxacin. The question of the facial nerve palsy, I will not answer it. I'm keeping it open until now. So if someone answer it and answer it right, then I will give him, so the price is 1 hour, okay, 1 hour face, one-to-one teaching with me. Okay, so Dr. Melania, I already contact her, and we are discussing when she can take the one-to-one hour. And the facial nerve palsy, who will answer it? He will take 2 hours, not 1 hour, because it's very difficult to answer. Okay, I'm increasing the price. Okay, this 2 hour free teaching. Okay, so please go listen to facial nerve palsy, try to answer the question, and then the price will be 2 hours free teaching. Okay, any question, doctors, before concluding and finishing? I'm very happy to answer any question. I hope you learned something from today. Any questions, doctor?
Thank you very much, Dr. Slim.
No problem at all. No problem at all. I hope all of you learned something. Okay. I will just I will leave you all, I will stay until all of you leave because my computer is stuck. So if I leave, the recording might be lost. So I will just ask you all to leave one by one. And if anyone have any question, I'm more than happy to answer him. Okay. So I will stay until everyone leave. I will see you next week, doctors. I promise. Okay, promise. Next week will be, more challenging case in female health. Okay, I promise. What you will learn from me will not listen to it in anywhere else. Okay, yeah. Take care, doctors. All the blessing, and wish you the best in your exams.